we've got a short conversation about certain, patterns of resistance and Mycobacterium tuberculosis. So for patterns of resistance, do you need examples for those 8 mechanisms that I gave you last time? Drug modification, target modification. No, you don't need examples. What you do need to know, though, there is a list of common acronyms like MRSA. 2 things. When I say what does it stand for, what is it resistant to? Methicillin. What kind of microorganism is it? Staphylococcus aureus. Or, for instance, CRE. What kind of microorganism is it? Enterobacteriaceae. What are they resistant to? Carbapenems. Does that make sense? Basically, those are the types of the questions that I'm going to ask you, because those acronyms are used in the clinical practice very, very often, and I want you to know what they mean. We clear? We good? Moving on? Okay, Mycobacterium tuberculosis. Let's talk about this bug. By the way, originally it was zoonotic. It was acquired from cows. But now it's not. It's a human pathogen. So let's start with the transmission route. Respiratory transmission from human to human, very contagious. A lot of asymptomatic infections. Majority of infections are asymptomatic. Only a small fraction of people who are getting infected develop the symptoms. So now, how does the infection work? So Mycobacterium tuberculosis bacteria infect macrophages. Which results in chronic inflammation. Your immune system tries to get rid of those infected macrophages, which results in the pathology due to their own immune response, mostly. Okay? Now, in otherwise healthy adults, so I'm going to put in immunocompetent people, okay? Here's what happens. The infected macrophage, along with the necrotic tissue around it and all the white blood cells that are dead, gets surrounded by layers of fibrin, okay, forming what's called a granuloma or tuberculoma. And that results in the latent TB. There are no signs, no symptoms. It can be tuberculoma in the lungs, and it can sit there for many, many, many years. Does that make sense? In immunocompromised patients, if you would look at the history of tuberculosis in people, usually those are people who are nutritionally malnourished, who are immunocompromised for one or another reason, weak, poor, all that kind of stuff. When I say reactivation, you have to appreciate it's not reactivation in the herpes virus sense of reactivation. It's not like it's just the main feature of Mycobacterium tuberculosis. It's a very, very slowly dividing bacteria. So once the immune system is compromised, bacteria starts to spill out of the granuloma, and that results in a primary tuberculosis with the typical symptoms of cough, bloody sputum, fatigue, night sweats. Next time you go to a physician and they ask you to fill out the questionnaire, you're going to have these questions basically. Every time you go to a physician and answer questionnaire, they screen for Mycobacterium tuberculosis. Does that make sense? If primary tuberculosis is not taken care of, often it progresses to secondary or so-called extrapulmonary, not extramedullary, extrapulmonary tuberculosis. Which involves organs like heart, bones, kidneys, brain, and generally speaking, extrapulmonary tuberculosis is in most cases lethal. Okay, two big problems. So first of all, diagnostics. So microscopically, acid fast stain, Ziehl-Nielsen stain, everybody knows TB test, right? So that's the kind of the old way. You can do TB test two ways. One, traditional intradermal inoculation, or you can collect blood and do the analysis for the TB antigen. This one, the blood-based, is more modern and more reliable. For instance, I have been vaccinated against tuberculosis, speaking of which. So I have a pretty good chance to show up positive on the TB test. That makes sense? So, vaccine, called BCG. The vaccine against tuberculosis is really marginally effective. So, in the United States, nobody gets BCG vaccine because it will screw up the test results for tuberculosis. Does that make sense? Once you get vaccinated, you can't really distinguish between your immune response to vaccine and your immune response to an actual infection, and this is what gets tested in TB test. Now, in other countries, like in the country where I'm from, in Russia, every child gets BCG vaccine because it reduces, first, the transmission. It has very low efficiency. But on the population scale, it reduces the transmission and it reduces the chance of developing extrapulmonary tuberculosis. Does that make sense? And basically, you look at the prevalence in the population. So prevalence of TB in the United States is very low. Prevalence of TB in Russia is pretty high. Just higher chance of exposure. Does that make sense? Any questions about TB here? Last bit about this bug. Slowly, very, very good question actually. Not that I came up with it, but which microorganism is harder to kill with antibiotics? Slowly replicating or rapidly replicating? Because when something divides quickly, you have to maintain a concentration of a drug at a certain level for a shorter period of time. For Mycobacterium tuberculosis, even in the lab, the generation time, we're talking about a week. So it's super slow. Does that make sense? So you have to maintain the concentration of a drug, the high levels, for months. The course of treatment is 6 months minimum. Many people can't afford that. And they, resort to shorter courses which kind of give them temporary relief, but also promote antibiotic resistance. And now there are strains of tuberculosis that are what's called totally drug resistant, TDR. There's MDR, multi-drug resistant, XDR, extensively drug resistant, and TTR, totally drug resistant. Now, as I mentioned before, this is why I use tuberculosis to exemplify drug resistance. When you have totally drug resistant microorganism, it doesn't mean that you can't treat it. You have to treat it, okay? But you have to use combination of drugs, you have to use higher doses, all that kind of stuff. Am I clear? And that can kill a patient first.